let's think about something from a payer perspective then, which has more value. You can define value any way you like, Mike. Is it immunotherapy or genomic precision therapy?
I don't know.
You didn't think very long about that.
Well, I've actually been thinking about it a long time. See, that's why I can answer so fast.
You.
So, you know, it's a horse race, right? And I don't mean to trivialize this, but there are different ways to get at the problem. They're both intellectually satisfying. I'm not sure there's a huge cost differential between them. So I think we will find out. The data will tell us what the right approach is.
Are they mutually exclusive?
They are not. I think not.
However, they're both, they're cost additive.
Maybe yes and maybe no. So I think it's a mistake, and I felt this way for a very long time, to focus solely on what the cost of the infusion is. I think we need to think about other things when we think about the cost of care of a cancer patient. So, you know, if you look at the cost of an episode of care for a cancer patient, about 25% is the chemotherapy. But another 20% is imaging, another 30% is hospitalization. All I'm saying to you is this. If the Institute of Medicine is right, 30% of healthcare is wasteful. As we get into a world of precision therapy, the opportunities for improving care and controlling cost is not keeping the right drug from the right patient. Keeping the patient out of the hospital, keeping them out of the ER, dealing with their symptoms at home, knowing when to say when. Mm-hmm. And I can't stress number 4 enough. This is, again, my opinion, not Aetna's. But the greatest ROI, and this is from work we did with U.S. Oncology, is really on end-of-life care and doing the right things at end of life.
Also, I think this would be an appropriate time to bring up the encapsulation of care. In other words, if you're going to give immunotherapy, right, you know what that cost is up front, and that's it. It's the gift that keeps on giving, because once you satisfy the immune response, it's going to keep working. Whereas if you give traditional chemotherapy, you're going to be paying out of pocket.
Now, let's be clear. No one is saying this is curative therapy yet. Maybe it will be someday. Okay. So let's just recognize that there's an episode of treatment, and how long that episode's going to spend. Neither of us really know for immunotherapy.
But let's hold that thought for a second, because as data develops with the use of ipilimumab, at least in melanoma, there has been, or there is, a plateau of survival in patients who are out 3, 4, and 5 years. So if 18% of your patients are alive at years 3, 19 or 18 or 19 at 4 and 5, some of those patients are probably cured. And the best data from the longest follow-up at 7 and 8 years suggests that if you have a complete response or a near complete response made a CR by surgery with IPI and melanoma, you're going to be alive continuously in remission 90-some-odd% of the time out at 7 or 8 years. So maybe those patients are cured.
I want to put this on the table without comment. I've been doing this kind of broadcast for a long time. One of the very few, if not the only time, I've heard the C word in this context. Whether or not we can use it reliably, all comers across the board, the fact that we're even discussing it is remarkable.
The fact that in current targeted trials, for example, with BRAF/MEK drugs in melanoma, we're seeing patients on protocol, and they come in and you look at the chart, it's week 140, week 170, week 180. I mean, that's unbelievable in melanoma. That's phenomenal.
Well, let's talk about gatekeepers then, because as we're moving into alternative reimbursement models, I think we just heard that providers may be increasingly be called upon to be gatekeepers here. In terms of cost, in terms of outcomes, how fast is this happening, and what do you think the impact is going to be?
Well, I think the ultimate outcome is survival. Okay. If I were a cancer patient and I had treatments pitched to me by my oncologist, my first question would be, how long am I going to live compared to not having treatment or compared to the usual control treatment? And how am I going to feel? So it would be essentially what we call quality adjusted years of life prolonged. And that's not a trivial thing to calculate, and that's what I want to know. The problem is, in the medical oncology business, at least until recently, we haven't been able to quantitatively assess what that benefit would be. Now we have more data. And I would agree with what Mike said. What, 30% of everything we do is wasted? I've been saying that since I became an oncologist 25 years ago. And I was absolutely convinced that at least a third of what I did was a complete waste of time. perhaps more in melanoma in the old days. Thank God I'm an investigational oncologist, so what I do is sometimes the utility is difficult to assess, but I truly believe much of it is wasted.
But who
That's
better
got to
to
change.
Who better to assess? I mean, I guess now that I'm listening to you, who better to assess the clinical outcome, the clinical impact, the appropriateness of therapy, and the appropriateness of the money spent than the guy or the woman with the boots on the ground, the provider?
Absolutely. And I think at the end of the day, I think the new healthcare reforms, should give us more opportunity to have a say into that. Now, I think what the challenge is now we're gonna own that more. I mean, that's going to come back to us in terms of a reimbursement model, and that's something that's that we don't have a lot of experience with.
It's something I think providers eventually will welcome. That's my personal opinion, not Aetna's.
No, actually, but I'll tell you this. So I think the interesting thing is this, right? So we have been stuck for a very, very long time in a paradigm of designing clinical trials with a view towards what registration for that drug should look like. That's the way it works. That is going to change because now there's going to be a burden on the innovators to look at meaningful outcomes that will allow them to position their product, immunotherapy product, targeted agent, whatever it is, to position it in a global treatment for that patient. And so it really shifts the burden of identifying value. And I'm all for that. As a healthcare consumer, I'm all for that.